Good morning, everyone. Can you hear me?
Good morning. Yes.
Okay, wonderful. Sorry, I'm a little bit late. I was trying to get my animals situated. Oh, I guess I should turn my video on as well. There we go. All righty. You guys not able to see me? I
We
can't even
cannot
see
see
me.
you.
Where am I? You're just staring off into nothingness here. There we go. Hi. All right. Okay. All right, so welcome to Module 3B. Okay. We broke Module 3 up into 3 different days because there's just a ton of material to cover. Okay. Um, but what I wanted to know before I even get started was, do you guys have any questions at all from anything that we have gone over so far?
And I'm here as well, Professor Castillo. So, if you guys have any questions for me as well, please don't hesitate to ask chat, verbally. There was just one thing I did want to address. Someone had asked about the definition of infertility, which, we talked about in lecture was inability to conceive after 12 months, right? So you might see differing on that based on age. Like sometimes women after the age of 35 considered infertile after 6 months, whereas younger than 35, 1 year. Your book, the three books that I checked, your med surge, I think it's med surge, the principles of nursing, and your maternal newborn, they all specifically just state after 1 year. They don't differentiate by age. So I would know what your book says because that's the resource that you're going to have to EBR, your assessments, and everything like that. So I follow that just to know that you might see kind of different stuff if you're looking online or something like that. But I wanted to address that. But does anyone have any other questions?
Okay. Thank you for addressing that, Professor Castillo. Something else that I wanted to personally address too was to make sure that you're staying up to date on all of your assignments. They do have due dates. They will need to be done before you even get to sit for that assessment. So please make sure you get them done. Try not to wait until the last 11th hour kind of thing because there's a lot of assignments that need to be completed, and I don't want you to have to spend your last time in this portion of the block doing assignments when you could be studying for your material for your assessment, okay? So please keep up with that. What is our definition of full term? 40 weeks, okay? Anywhere from 38 to 40 weeks is considered full term, okay? After 40 weeks, it's post term. All right, so let's start off with, I guess I need to share, don't I? Can't really do too much if I'm not showing you what I'm doing. Okay. Oopsies. I will get it together here in just a moment. Okay, can you all see my screen that says electronic fetal monitoring? Okay, wonderful. Okay, so we have two different presentations today. So we'll do the first one, then we'll take a little break, and then we'll do the second one, okay? Now, when I'm going through all of this stuff for maternal newborn portion of this block, please remember and keep in mind that we are not trying to make labor and delivery nurses out of you, okay? There is a ton of material to know in this, and I want you guys to know the basics, okay? Stuff that they're going to ask you, maybe even in clinical, not just for your assessment, but the nurses on the clinical floors are going to say, hey, what does this mean or what does that mean? Kind of thing. Okay. So I don't want you guys to be like a deer in headlights and not being able to answer those questions. And they don't ask a lot of hard questions at all. It's very easy stuff. So what we give you here in this portion of the block is a lot more than what you're actually going to need to know. Okay, but we give you more so that you can understand the basics better. I hope that makes sense. All right, so there's two different ways that we can actually monitor our babies. Okay, one is by external or EFM, another is by internal or FSE, which stands for fetal scalp electrode, and then IUP, which stands for intrauterine pressure catheter. So external, you can see here. Remember yesterday I talked a little bit about when we're doing those Leopold's maneuvers to kind of figure out where the back is, because that's where we're going to get the strongest signal for our heart tones. Okay, and I told you there's two pieces. One is the ultrasound transducer. This one is for the baby's heartbeat. And this one is the toco diameter, which is or toco transducer, sorry. And that monitors the contractions. Okay. This one for the ultrasound, because it is ultrasound, it requires a little bit of gel, okay, on the other side of this so that we can pick up the heartbeat quite clearly that way. Internal, okay, internal, both of these objects go inside the uterus, okay? This one here is the fetal scalp electrode, and actually, and I hope in lab they're going to pass these things around. If not, we'll show them to you in clinicals. But what it is on the end of that is a really tiny, really short type of screw, and we just rotate just a little bit to screw it into the first layer, under the first layer of skin on the scalp, or even the presenting part, but typically it's the scalp. It doesn't hurt at all, okay? It doesn't cause any problems at all. So that goes in and that monitors your baby heartbeat directly. Okay, the other one is this portion here. This is called the IUPC. This goes right in, we slip it in, and both of these instruments are applied via vaginal examination. Okay, so this just slides right in and it kind of just goes up beside the baby and it monitors the exact amount of pressure that is exerted by that uterus. So when I see that we're doing internal, okay, can anybody give me a guess on actually what would need to be done or have happened already in order to put these two things inside? Does somebody take a wild guess? What is surrounding the baby? What is the baby's protective barrier? Yeah, the amniotic sac needs to be broken. Okay. They should be a little bit dilated, absolutely. If they're not dilated, we don't really want to do invasive procedures. But definitely that bag of water needs to be broken, okay? Because we can't get these things inside without breaking that bag of water. So that already has to have been done. All right. So when you guys get out there into the clinical field, you're going to notice this is the type of paper that's going to come out of the machines that we are going to be using to evaluate our baby's heartbeat. Now, just to give you an idea what the papers look like, this is exactly what it looks like. Sometimes there might be a blue kind of tint on the normal range of the heartbeat. So it would go from 100, I think 100 up to 150. It depends on what what area or what institution you're in. Some of them use that where there's that blue tint, and it's just kind of a quick assessment of noticing whether or not all of your heartbeats for the baby land within that normal parameter. You don't always see that blue tint, but when you do, it's there. Okay. But this top section here is all baby monitoring. Okay. This is all baby. And then down here, this is mom. Okay. So this is the ultrasound. This is the toco. So when you look at these, you can see there's a dark line here, a dark line here, and a dark line here. In between each of these dark lines is 1 minute. And then they're further broken down into 10-second intervals. Okay. That is so you can actually do your calculations as to how long the contractions are lasting, how far apart they are, so on and so forth. Okay. So fetal heart rate is measured in heart rates or beats per minute. Okay. And then contractions are measured in millimeters per mercury or pressure. Okay. And we're gonna, excuse me, we're gonna actually go over a few practice strip reading here. So when we're evaluating our baby, our fetal heart rate, okay, there's a few things that we look at in order to determine if the baby's doing well or not doing well. The first thing we always try to establish is the baseline. Okay, so we want to take a good portion, at least a 2 minute section of our fetal heart rate when there's no, say, accelerations or decelerations taking place, and then really evaluate where most of those little fluctuations land. I hope you remember yesterday I talked about, when you're looking at the fetal heart rate, it has little fluctuations. Okay, that's normal. We like to see that. Okay. The next thing that we look at is deciding whether or not what the variability looks like or those fluctuations. Okay. And then after that, we look to determine, are there any accelerations of the fetal heart rate or are there any decelerations of the fetal heart rate? And then from there, if there are decelerations, what type of decelerations and then what causes those? Okay, those are things that you're going to need to know. I'm going to go over all of that with you right now. Okay. So, okay, here's the blue portion. When I was telling you, some strips have this little blue strip portion here. Okay. That's just kind of like I said, a quick eyeball to say, okay, my baby's doing good. It's all within the normal parameters. Okay. But when you're looking at baseline, okay, you can see these numbers going up here. That's giving us the number for where we're going to determine what our baseline fetal heart rate is here. So in looking at these beats, or each of these fluctuations is a beat in the baby's heart, okay? When we're looking at these little fluctuations, we want to see on what line, 150, 140, 130, 120 kind of thing, on what line does the majority of all of these heartbeats land on? Okay, so if you had to quickly eyeball this, where do you think, or what line do you think the majority of these heartbeats all land on? Throw out a number. 145, I would definitely go with 145. Okay. This is 130 here, and then 135 would be kind of in the middle here. Not a whole lot of beats in that area, but this is 140 and that's 150. So a lot of beats in that area. So I would definitely go with 145. So very good. Okay, very good for your first strip read. All right. The next thing we look at is our baseline in this normal parameter? Okay, the normal fetal heart tones are 110 to 160. Okay, that is the normal range. If we have a fetal heart tones that are constantly being outside of that range on the top, then it's considered tachycardia, just like you or I. Okay. Or if a lot of our fetal heart tones or our baseline is below 110, we call that bradycardia. Okay. Bradycardia. The next thing we're looking at is variability, or how much of those fluctuations do we have? Now, when we go back to that last strip here, looking at this section, we see a lot of fluctuations, okay? That tells me that I got a real healthy heart. It's doing what it needs to do. Remember that our heart does not stay consistently at 68 beats per minute, 68, 68, 68, okay? We always have those fluctuations, always, okay? Same with baby. Those fluctuations are what's called variability, okay? So when we measure variability, there's four terms that we actually use. We use absent, okay? There's really no variability seen. Then we use minimal, okay, which is described here. Then we have moderate and marked. Okay, so I'll give you examples of all of those shortly. But here, okay, we have a lot of variability. So when we're looking at variability to decide if it falls under absent, minimal, marked, or uh, average marked, okay, or moderate marked, then, sorry, my cat is driving me crazy here. We have to look at a couple of minutes in between all of the other stuff that's taken place, okay? So we look at these variability here. And with what I do personally is I kind of eyeball, okay, I know my baseline, I've already established my baseline of 145. So I kind of eyeball what is the lowest fetal heartbeat that I can see on here. And it looks like it's landing on like the 130 line, okay? And then I eyeball what's the highest beat that I can see here, okay? And it looks like it's about 155. So in using my description of, excuse me, absent mild or absent minimal, moderate, or marked variability, absent is zero, there's nothing, okay? Minimal is 0 to less than 5 beats. Moderate is 5 to 25 beats. And then marked is greater than 25 beats, okay? So if I'm looking at this and I'm trying to establish the variability, I got my lowest at 130, or sorry, yeah, 130, and I got my highest at 155. Is that in between the 5 and 25 mark? It is, right? So I could call this technically moderate variability, okay? So down here you can see absent. There's no fluctuation here. Okay. Now, this isn't necessarily terrible. Okay. It's terrible if there's other things going on, but it's not terrible if we say maybe just gave mom some morphine for pain management. Our heart rate is going to settle down and it's going to kind of be a little bit rested. Okay. So is baby's. So what mom feels, baby feels. Okay. Here is an example of minimal variability. You can see some fluctuations, but it's very minute. Okay, and I'll show you marked and moderate coming up here. Okay, the next thing we look at is, are there any accelerations or is the heartbeat going above our baseline and staying up there for a few seconds? Or are there any decelerations? And if so, how deep are they going? I am so tired today. Excuse me for yawning. Oh my goodness gracious. I need some coffee. In any event, yeah, so when we have decelerations, then we have to further describe those decelerations. Accelerations are really great. Now you see we have our established baseline of say 145, okay? And then we have these nice accelerations right here where baby's heartbeat went above our baseline and for a few seconds, okay? It has to be at least 15 seconds long in order to be considered an acceleration. So just like you or I, say, for example, we are running on the treadmill. Our heart rate is going to really fluctuate. Okay, but every time we take in a nice deep breath, our heart rate's going to raise. Okay, so we're going to have an acceleration of our heart rate. Perfectly normal, very healthy. When we see that in a baby, very healthy. That tells me that I have a baby that has an intact central nervous system. Okay, when I don't see accelerations and I don't see variability, That tells me I either have a super sleepy baby or a baby that's in trouble. Okay. The next thing we look at are decelerations. And there's a few different types. So when we're looking at the decelerations, and I'm going to give you guys an acronym to be able to distinguish them, okay? So we have variable, early, late, and prolonged. So when it comes to decelerations, those are dumps underneath of the baseline. Okay, they're dumps where the baby's dumped. So either the baby's holding their breath, or maybe they have a tight nuchal cord because remember their umbilical cord is what gives them the oxygenation. Okay, if that's being pulled because it's tight or compressed, exchange is not going to take place, and we're going to start seeing those decelerations. So a variable deceleration is kind of just exactly what it says, variable, okay? They're U's, V's, W's, typically in shape. They are variable in time, so they can happen with or without contractions, okay? Now they are always going to be related to cord compression. Early decelerations. When we see an early deceleration, it looks exactly like mom's contraction pattern, okay? So mom's contraction here, and then we see baby's heartbeat. I can't curl my hand up enough, but then we see baby's heartbeat going down at the same time mom is having that contraction, okay? That's an early deceleration, very normal physiological response from the baby's head as it's being pushed against the cervix. Okay. We are okay to see those. So those are okay. That's due to head compression. Late decelerations are just like they say, late to the party being the contractions. Okay. The late deceleration is a deceleration of the baby's heartbeat. This is your contraction, the top of your contraction. The baby's heartbeat actually starts to decelerate right at the top of that contraction and then comes back up. Okay, that's a late deceleration. That is always going to be related to uteroplacental insufficiency, meaning the placenta is not functioning properly. All those intervilli, okay, all those little vessels that are going into and out of the cord, okay, exchanging between mom and baby are not working great, okay? And then we have what's called prolonged decelerations. Okay, these decelerations are just long decels that last a couple of minutes. Okay, and then if it goes into a change in baseline, then that has to be longer than 20 minutes. But this is prolonged is at least 2 minutes long. Okay, I want you to be concerned about variables, earlies, and lates. Okay. So the acronym to remember those is actually veal chop. So I want you to write out the word veal, V-E-A-L, in a downward fashion, and then chop in C-H-O-P in a downward fashion. Okay. So veal, variable, that's the variable. So write down variable, is always related to cord compression. So V is variable, C is cord compression. Okay. Early E and OK or head compression is the H in CHOP. Okay, so early and H. And then you have A accelerations, okay, in V or in veal, and then O in CHOP is okay. Those are okay. We like to see accelerations. And then L is for late decelerations, and the P in CHOP is for placental insufficiency. And that'll help you recognize those and then understand what they're due from. Is there a minimum requirement of 15 beats below baseline lasting? No, for decelerations, there's no minimal requirement unless you're trying to call it a prolonged deceleration. And if that's the case, it has to be 2 minutes or longer. Excuse me. Okay, so here's some examples, okay? These are variable decelerations. They're concerning because we know it's related to cord compression, but they're more concerning when they're deeper and lasting longer. Okay, so deeper down and lasting longer. So remember they're variable in shape. So they look like U's, V's, or W's. Okay. They can happen with contractions or without contractions. Okay. So these are variable decelerations. What do we do for variable decelerations? Okay. Our interventions for variable decelerations and late decelerations are all the same. Okay. Remember this, flip, fluid, and O2. Flip meaning reposition. Fluid meaning give mom some extra IV fluid. Okay. And O2, give mom some oxygen. All right. Flip, fluid, and O2. Those are our interventions in labor and delivery for everything. Okay. We want to turn her from side to side. We may or may not need to do what's called an amnio infusion. Now, if you remember back that IUPC that we put inside, okay, on the end of that, there are little tiny holes, and we can actually hook up regular IV tubing to the outside. There's a port on the outside of it, and we can run fluid through that into the uterus. Okay, and that fluid just kind of flows around the baby. And what it's good for is cord compression. Maybe like I said, the cord might be wrapped around the baby's neck and mom's water has broken. Okay, so we want to give mom some extra, baby some extra fluid inside there to kind of cushion things and maybe loosen the cord up. We might even do an amnio infusion for something like that's called meconium. Okay. Meconium is baby's first bowel movement. And if they're super stressed, they actually pass that while inside the uterus. And it depends on how thick it is. If baby passed a whole lot of it, then that fluid can be very thick. And remember, they practice inhaling or breathing that in. Okay. They go through those motions. They can actually, on delivery or right at delivery, when they take that first breath, if there's any fluid or meconium fluid left in there and they take that first breath, they actually can aspirate all of that into their lungs. We don't want that. So sometimes we will do an amnio infusion to thin that meconium fluid out. Okay, sometimes. But most of the time we do an amnio infusion for variable decelerations because we know it's related to cord compression. And cord compression, we can add fluid and kind of give it a little bit more cushion. Okay, early decelerations, they look exactly like mom's contraction pattern. So if I were to actually flip this paper upside down, I could then say this is mom's contraction pattern and this is baby's decelerations. That's how it mirrors. It happens exactly the same time. Very normal. Okay, we're okay to see those. Interventions for early decelerations. Well, we know that they're due to head compression. Okay. So we might want to check and see how close mom is to delivery. All right. Because we don't typically see early decelerations until mom is very close to delivery. So if that's the case, I want to make sure I check her cervix. And then I know she's close to delivery, so I'm going to definitely prepare for that delivery. Late decelerations are very concerning because they are caused by what? What causes a late deceleration? Remember your acronym VLCHOP. Placental insufficiency. Very good. Okay, placental insufficiency. So when mom contracts, okay, then the baby starts to feel the effects because baby's been doing good. Okay, up until mom contracted. As soon as mom's uterus contracts, remember all those vessels constrict, okay? Baby doesn't feel the constriction until right at that time when that uterus is contracting. It's not constricted here, so baby's able to exchange nicely. But as soon as mom's uterus is nice and tight and contracted, they feel the constriction. So that's why the baby's heartbeat goes down, or it's a late deceleration. Okay. It takes a few minutes or a few seconds for it to revive or come back out. So once that uterus starts to relax, the blood vessels open up and baby comes back to normal. Okay, we're normal again, then mom's uterus contracts again, the vessels constrict, baby goes down. Okay, that's placental insufficiency. And what we like to do here is interventions, and we know it's placental insufficiency, so we want to do flip fluid and O2. Okay, so here's our interventions. Turn the patient. Now, this doesn't mean either one of these interventions for variable or late. Okay, we're not going to just turn our patient one time and call it a day. We might have to keep flipping back and forth until we see that the baby is doing better. Okay, so turning the patient, giving her a bolus of fluid, giving her some oxygen, all right, calling the provider because definitely we want to let them know that this baby is not doing so great. Okay, give them a little bit of a heads up. And then if mom is on oxytocin, say for an induction or augmentation of her labor, we're going to want to turn that off. We want to stop the uterus from contracting. And so we're going to give mom some tocolytics or uterine relaxants. Okay. We do what's called intrauterine resuscitation here, meaning the baby can kind of normalize itself back to hemostasis in inside the uterus. It works better for the baby to resuscitate itself in the uterus as opposed to us quickly pulling the baby out and trying to externally resuscitate this baby. Okay. So here's our prolonged decelerations. Okay, remember each one of these is a minute long. So this deceleration is just happening before the contraction starts. And it's just going down, 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 down. This is when nurses actually start to really freak out because we're never sure if it's going to come back up. Okay, if it's going to go down or if it's going to continue to stay down. Once it goes down for a long time, we are running back to that OR to get this baby out by C-section. Okay. So interventions, okay, definitely going to do a vag exam because one thing that happens when we look at these prolonged decels, the main thing that causes these is a prolapsed cord, meaning the umbilical cord has kind of fallen out the vagina before the baby has even been born. That's called a prolapsed cord. That's when we typically see those prolonged decelerations. Definitely going to need to prepare for an emergency cesarean section if that's the case. Okay. Oh, and here's your next slide. Veal chop. Okay. Whoops. I went through that very fast, didn't I? Veal chop. Okay. Variables early as axels, lates, all related to cord, head, okay, and placental insufficiency. So on your assessment, when you get your scratch paper, write this out and that'll help you. So the other thing that we do is we categorize our fetal heartbeats, okay, our monitor strips. And this is all by the NICHD guidelines, our National Health and Child Care or something like that. Can't remember exactly what it stands for, but it's NICHD. And they kind of come up with this categorization thing that we need to do. So what we do is we categorize them as one, two, or three. One is perfect. We have good variability, nice accelerations. Sometimes we might not see any accelerations, but that's okay. But we should have accelerations, but definitely no deceleration. So baby's great, category one. Okay. Category three, baby's not great. We need to intervene. This is probably going to be an urgent to an emergent situation. Okay. So baby's bad. Category two, everything in between. Okay. Everything in between. So we have good, we have indifferent, and we have bad. Okay. The next thing we do when we're looking at that monitor strip is now we're going to start to evaluate mom or the contraction pattern. So what we do typically is we're looking at how often is mom contracting? Okay. How long are those contractions lasting? And then how strong are they? Now, you notice when I talked about monitoring, you have external monitoring and you have internal monitoring, right? External monitoring, we can palpate the uterus using our finger pads. Okay. We palpate the uterus for strength. And how I determine it is this would be a mild contraction, just pushing on my cheek. I can indent the uterus a little bit. Okay. This would be a moderate contraction. I can push my nose in, but there is some resistance. And then this would be strong. I cannot push that uterus in. So this would be palpated at a strong contraction, moderate contraction, mild contraction. Okay. That's externally. Now, if mom has an IUPC in, remember that measures the exact pressure of the uterus. So we measure that strength by something called Montevideo units. And that each facility has a different amount as to what they consider sufficient Montevideo units in order to make labor progress. Okay, so, and I think typically it's about 240 to 310 millimeters of mercury, 240 to 310 millimeters of mercury. And what we do is we calculate on that 10-minute strip, we just choose a 10-minute strip every 30 minutes, and we calculate how often mom's contracting. And then for Montevideo units, we calculate how high those contractions go up on the numbers. And I'll show you in a moment here when we do some practice. Okay. So that's the strength. Then we look at duration, or how long are they lasting? Now, typically we want contractions to last anywhere from 60 to 90 seconds because that's really going to give that cervix some good pressure consistently to make it dilate. Okay. And then frequency, how often are they happening? Every 2 to 3 minutes is a nice contraction pattern. But when they're every 5 minutes, remember it's the uterus or the cervix is not going to dilate very quickly if they're every 5 minutes. Okay, so we want them every couple of minutes. So here we're going to practice. Okay, there is also you know what, I think what I'd rather do is um, oops. I think you guys have a link to this. I'll actually post it in our chat box so that you guys can copy and paste it. But this is a really cool little game, okay, to play. So what we do is, if this is real time, okay, real time practice. So what you do is you just press the start button. You say who you are, so you're going to be registered nurse. And then it's going to give you some strips to read, and you kind of practice by pushing on these buttons down here. So remember, the first thing we do is we look at a baseline. Okay, so where on this strip do you think most of the heartbeats are landing outside of the accelerations? So we'll look in this area. If this is 130, this is 140. So is this a normal baseline? Is it within that normal 110 to 160? Okay, so we can click normal. We got that right. Now we look at the variability. Do you think the variability is absent? Do you think it's minimal, moderate, or marked? Okay, variability is in here. Remember, if you do a quick eyeball of the lowest beat and the highest beat, where in that value does it land? Okay, so if we say moderate, we got correct. Okay. Are there any accelerations? Absolutely, right? So we say present. Now we're going to say, are there any decelerations? Well, just for S's and G's, I'm going to say yes, late and prolonged, okay? Uh-oh, I got it wrong. Okay, I got it wrong. Then it's going to ask you to categorize it. Remember, 1 is perfect, 3 is terrible, 2 is everything in between. This baby looks perfect, right? So I'm going to say normal. Do I have a good contraction pattern every 2 to 3 minutes here? Do I have too many contractions, one right after the other? Okay, that would be called tachysystole. Okay, so I'm going to say, you know what? I think I need to adjust the toco because I can't quite see anything. So I'm going to put that. Uh-oh, wrong again. Okay, so then you just click next and it gives you a whole new strip. Okay, so something kind of cool to play with. I won't spend too much time there. I want to go over these strips though. Where am I here? Whoops, wrong one. Okay. All right, so here, let's look at this strip. Okay. Now, first thing we do is what is our baseline? So is the baseline within 110 to 160? Okay. Yes. All right. Now, what is the value? What is the number of our baseline? Where's the majority of our fetal heart tones landing? So this is 130, this is 140, this is 150. I'd probably say about 150. Okay. So now we need to look at accels or decels. Do we have any accelerations? Nice accelerations. I'm not seeing any, but I am seeing some decelerations. Now I need to determine what kind of decelerations. All right. So what do they look like and where are they happening? So if I'm looking at the contractions, okay, contraction here, decel starts after the contraction. Contraction here, decel starts after the contraction. So what are these called? This is the party. Baby's late to the party. Okay. What are we going to do for this patient? What's our interventions? What do we do for any patient that's having decelerations? Flip fluid O2. Very good, Seth. Okay, wonderful. Okay, here's another one. First of all, is our baseline within the normal parameters? Yep. Okay. What is the value? What is the baseline number? Where does the majority of our heartbeats land? 150. Okay, good. All right, do we have any accelerations? Beautiful accelerations, right? Do we have any decelerations? Nope. Okay, what about our contraction pattern? Is it? Hey, stop. Are they regular? Every 2 to 3 minutes? Okay, we really haven't practiced reading contractions yet. So let's start here. Okay, so this is a toco, meaning it's external. Okay, this is external contraction monitor. So what we do when we're measuring contractions is we start at the beginning of contraction 1 to the beginning of the next contraction. Okay, so again, this is 10-second intervals in between 1 minute here. So we're at this interval, just here, we're going to start at about halfway through. Okay, so I'm going to go 1, 2, whoops, hey, got click happy, 2, 3. So this contraction is about 3 minutes apart. Then we're going to start here and count to this one. So I'm going to go 1, 2.5. Okay, so every 2.5 to 3 minutes apart. All right. Now I'm going to palpate them. So mild, moderate, or mild, moderate, or strong, right? I'm going to palpate. And when I palpate the uterus to find out how strong they are, the uterus, when it's contracting, is contracting from the top down. That's where the majority of the muscle is. It's at the top of the fundus. Okay, so that's where I'm going to palpate. All right. So I'm going to say we measured this and this was a mild contraction. Okay, just for S and G's. So if this were internal, okay, if this were internal, this would say IUPC internal. Okay. If this were internal, how I would calculate my Montevideo units, the frequency is the same, but the strength is different. So for Montevideo units, my uterus is totally relaxed at this line right here. Okay, so that's where I start, and then I count upwards. Each one of these lines up is 10 seconds. Okay, so I'm resting on the 10. So I got 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 10, 20. Okay, so I got 120 there. And this is in a 10-minute window. So this is a 10-minute window. So I got 120, then I got 10, 20, 30, 40, 50, 60, 70, 80, 90, 200, 210, 220. Okay, then I got another one here, 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 110. I'll say 120. So I have 360 Montevideo units. So that's what my number would read. Okay. Does that make sense? A little bit, just a little bit. Now, again, you're not going to need to know Montevideo units for your assessment. This is for clinical. Okay. All right, here's another one. We are going to look for our baseline. What do you think our baseline is? Sorry, it's about 130. Okay. What about our variability? Do we have good variability? Is it absent, minimal, marked, or moderate? Eyeball the lowest one, eyeball the highest one. So I got 125 up to 140. Is that in between 5 and 25? So that's moderate. Okay. Do I have any accels? No accelerations. Do I have any decelerations? Yeah, I do. Now, what kind of decelerations are they? So let's look at the timing and the shape. When do they happen? Well, this happens before the contraction. This happens after the contraction. Okay, so they're variable. Okay. They also have the U, V, or W shape. So now I'm really convinced that they're variable. So what's going on here? If they're variable contractions, what's causing it? Cord compression. Very good. All right. And contraction, let's measure how this contraction is. So we start at the beginning of this one and we go to the beginning of this one. So we got 10, 20, 30, 40, 50, 60. That's 1, 10, 20. That's 120. 30, 40, 50, 60, that's 2, 10, 20, 30, 40, 50, 60, 3, 10, 20, 30, 40, 50. So about 3 or 4 minutes long apart. Okay, so this isn't going to do us any good. It's not going to labor that cervix down, right? Okay, we got couple more slides to practice on. Give me 1 second. I just got to get my dog out of here. Okay, sorry about that, guys. Okay, so looking at this strip, what's our baseline? About 155, very good. What's our variability? Minimal, yes, very good. It's not completely absent because there's still a little bit of fluctuation there, but it's not a lot of fluctuation, so it's minimal. Okay, do we have accels? No accels. Okay, do we have decels? Yeah, we do. But when do they happen? So we got to figure out what kind of decel. So here's a contraction, starts here, starts after the contraction. Here's another after. So these are late decelerations. What's causing these decels? Not head compression. Those are variable decelerations. Remember veal chop. Placental insufficiency. Now, taking a good quick look at this strip, what do you think is causing the placental insufficiency here? Look at this contraction pattern. The uterus is not able to relax at all. Okay, every minute to minute and a half, it's contracting. This is way too close. This is what we call tachysystole. So we can't even get enough oxygen to our baby because we're already starting a new contraction. Okay, so this is too much. So if mom was on oxytocin, I would definitely want to turn down the oxytocin or even at this point, turn it off. Let the uterus relax, baby get back together, and then, whoops, where am I here? Why did you guys disappear? Why did you guys disappear? Okay, there we go. Um, Sorry about that. I would definitely want to give this baby some relaxation. Okay, next slide. This is our last practice one, okay? So what's going on here? Oh, my stars. Okay, what's our baseline? I'd say about 160. Okay, this 150, this 160. What's our variability? It's not completely absent. Okay, if I'm looking in here, it's not completely absent. There's not a whole lot of it either, so it's minimal. Okay, minimal variability. Do I have any accels? No. Do I have any decels? Yeah. Okay. First of all, this is a contraction right here, so this is a late deceleration. Contraction here, this is a late deceleration. And then I have, this is a prolonged deceleration. Look at what's causing it. This uterus is one on top of the other. So this baby is definitely saying, if you don't get me out or stop this uterus from contracting, I'm dying. Okay, look how low this is. This is down into the 30s. Okay, so this baby is in big, big trouble. All right, couple practice questions here. The nurse is assessing the fetal monitor on a laboring patient and sees several temporary increases in the fetal heart rate. What does this mean? Is this good? Is the baby in distress? Is the baby oxygenated? B, yeah. Nice accelerations. This baby's well oxygenated. All right, that's it. The nurse is caring for a laboring client and sees a few sharp decreases in fetal heart rate on the monitor, which quickly return to baseline. What is your priority intervention? Bolus the fluid volume, turn the patient, check the cervix, or reposition patient to relieve cord compression. Okay. Sharp decreases, okay, that quickly come. So that's a sharp decrease. That's like a caret or a V. Okay. That's cord compression. Giving her fluid, yeah, that's an intervention. Turning her to increase placental perfusion, it's not a late deceleration. So turning her is okay, but this isn't correct. Okay, that's it. So that makes B not correct. Checking her cervix to verify head compression. Well, it's not an early, okay, it's not mirroring the contractions. So we might want to check her cervix, but I don't want to do, it's not related to head compression. But we do want to reposition the patient, and the latter half of this answer is correct to relieve cord compression. All right, guys, that is our first half of the lecture. I'm going to give you guys do you guys want a 5 or 10 minute break? 5 minute break? Okay, let's do 5. We'll meet back here at 10:03. 02, 10:02. Okay, are we all back? All right, any questions from the monitoring part? No? Okay. All right, well, now we're going to go over one of the major issues or diseases or syndromes, however you want to look at it, that happen during pregnancy. We're actually going to talk a couple of them about the biggest ones in pregnancy that we worry about, and that's gestational hypertension as well as gestational diabetes. Okay. All right, so you guys have, can you all see the gestational diabetes screen? All right, so what do we want to get out of this? Well, we want to be able to understand what goes on in the pregnancy during a gestational diabetic pregnancy, more specifically with relation to mom's symptoms, mom's interventions, and then what can happen to the baby with relation to potential abnormalities and risk factors associated with that for both mom and baby. Okay. Um, and Yeah, as with anything that we do, education is a big key during if a mom is diagnosed with gestational diabetes. Okay, so what is gestational diabetes? Well, it's defined as a carbohydrate intolerance with the onset happening during pregnancy. Okay, well, we know that diabetes mellitus is before anybody's even pregnant. Okay, that's type 1. And then you have type 2, which is typically related to our obese patients. Okay. Type 1 requires insulin, type 2, not really insulin, but they do require medication such as metformin or anything like that, but not all the time. Sometimes it can be held off with diet and exercises, okay? But when they're pregnant, okay, we do what's a test called GTT or glucose tolerance test. And we do this test for our patients typically between 24 and 28 weeks. Okay. What they do is they drink, well, it used to be, I don't know if it's changed or anything, but it's a little tiny bottle of orange drink and it's really gnarly tasting. Moms have to be NPO before it, and then they drink that, and then they get tested. Their blood glucose gets tested at 1 and 3 hours if need be. Okay. We would send a mom off for this test or have them do this test specifically if, say, we dipped their urine with the urine dipstick and it came back that she was spilling glucose. Okay. Well, number one is she obese? Number two, does she have a history of having gestational diabetes or even a large baby history? Okay. Or is she just simply spilling glucose because maybe she just came in after eating Wendy's Frosty? Okay. So those are things that you need to kind of go over with mom beforehand. Some of the risk factors associated with it is a family history, obesity, hypertension, and gestational diabetes actually go hand in hand for the majority of the time. Not all the time, but the majority of the time we see both of these disease processes taking place. Okay. Maternal age has a big risk factor associated with it being greater than 35, of course. They call that geriatric pregnancies now, and I can't stand that they call us geriatric women at 35. But in any event, like I said, previous history of a diabetic being diagnosed with a previous pregnancy. History of fetal demise is also something to be aware of because sometimes if somebody is gestational diabetic and they had not had prenatal care and we didn't know, and that might have been the reason for that demise, we want to do some extra testing on that mom, okay? And particularly if mom has a multiple gestation, so they're maybe carrying twins or triplets or so on. Okay, the nutrients change during pregnancy, the nutrient requirements specifically for the fetus. So the fetus is actually like a parasite. It feeds off of mom. during the pregnancy. So everything that the fetus needs, it's going to take from mom, regardless if mom is healthy or not. Okay, that happens even in the animal kingdom. Okay. But when it happens to moms that are already compromised with the diabetes, then babies tend to they come out a lot bigger than what they should. And we'll go over that a little bit more here moving forward. If mom is already on insulin, say she's a diabetic type 1, her insulin demands tend to really increase big time for the most part. But there are occasional pregnancies where moms actually do better with little bit of insulin as opposed to say they were on 6 units 2 times a day before. Sometimes they do better on 3 units 2 times a day now, kind of thing. Or they might have to actually go up to 18 units 2 times a day. So it's specific to the woman. Again, everything's individualized. There's no, you know, black and white situation in this stuff. It doesn't happen all the time. So when the pancreas is unable to produce sufficient insulin or it's not being used effectively, then gestational diabetes is typically the result, but not always. Okay. So what I'm going to do is get you guys into your groups again. And what we're going to do is create a Venn diagram with the compare and contrast of gestational diabetes to type 2 diabetes in the general population. Okay, so what you want to include is the onset, the risk factors, the consequences, and treatment. You all know how to do a Venn diagram, right? Okay, the commonalities are in the center. So this would be gestational, this would be type 2. Okay, so I'm going to break you off into your groups and we'll take, say, 5 minutes into the groups. We've got 20 here. All right, your rooms should be opening. T, Athena, and Matthew, please go to your assigned groups. Matthew and T, go to your assigned groups, please. Matthew, are you there? Did I lose people? Was people present in your rooms? Yeah. Okay. Well, I guess they decided to leave altogether, which is sad. But anyway, for those of you that are here now, what did you come up with? Oh, here we go. So for the Venn diagram, what did you guys come up with?
For onset, I said for gestational diabetes, it's usually between 24 and 28 weeks. And then for type 2, I said either not pregnant or like later in life because it's usually related to obesity or some lifestyle factors.
Okay. Anybody else want to add anything? What group were you in that was just speaking?
I was in group 3.
Okay, group one. Anybody from group one in here?
Yes. For we had the same onset for gestational, and then we did a little bit of research for the onset of type 2, and it says usually over the age of 20 is when that onset is. And then I guess
Okay.
I can cover risk factors as well.
Okay.
For risk factors for gestational diabetes, we said family history, obesity, hypertension, glycosuria, um, maternal, older maternal age, previous pregnancy with gestational diabetes, history of a large baby, fetal demise or congenital anomaly, and then multiple gestation. And then for risk factors for type 2 diabetes, I guess in the middle of our Venn diagram, because we just listed them above and below, the middle would be family history, hypertension, um, and then for just type 2 diabetes, that high BMI, poor diet, lifestyle, age, previously having gestational diabetes, PCOS, hypertension, and then like hyperlipidemia or high cholesterol.
Okay, good job. Good job. How about group two? What is treatment? Talk about treatment.
For treatment for gestational, we put insulin if it's needed. And then for type 2, usually we're going to give those oral meds first, and then, if anything is worsening, then we would go to the later measures. And then for the both, we put treatment is just diet and exercise.
Okay, good, good. Yeah, both require treatment with, basic stuff, starting with the diet, making sure that they're eating good nutrition, regular exercise, not overdoing it, but, just regular exercise. With gestational diabetes, oftentimes they're not put on any kind of hypoglycemic medications, such as insulin. They do sometimes take metformin, but we pretty much try to control it with diet. And again, if that doesn't work, then of course they're going to go on PO medication, not typically insulin for that. And that was insulin would be saved for, the real brittle person that's not responding to oral hypoglycemics. Good job, guys. Okay. Complications for mom and baby. So, whoops, I was trying to get you guys minimized, and I minimized my other screen instead. Um, so lots of things can go on for both mom and baby. So if you think about, gestational diabetes or even diabetes in and of itself, if you think about the baby, okay, we're pregnant and we have this baby in there, and mom is spilling sugar constantly. Okay, so she's spilling glucose. That's telling us that baby's actually living in a real, just kind of sugar water. Okay, because they're spilling glucose as well. So they're swimming in nothing but a pool of sugar. Okay. That's their life. Okay. Their pancreas isn't doing any work because mom's pancreas is doing the work for them. Okay. So, but their sugar is very high. So it's very dependent on how mom can control her sugars, how that environment is going to stay. So if mom's not controlling her sugars, then baby's also spilling sugar and again living in that sugary environment. What does sugar do for us? In general, what does sugar do for us when it comes to body size? Larger. Yeah, we become fat, okay? Because where our body needs protein and we don't break down sugar into a protein, okay? That's protein. So it just gets stored in fat cells, and the more we eat, the more fat we become, okay? So that's the same with the baby. So the longer they're in that sugar hole, okay, the fatter they're going to be. Now, if you think about it, okay, we have a big fat sumo baby, okay, trying to come out of a vagina that's only meant for, say, a 7-pound baby. And now you have this big, giganto 10-pound baby coming out of there, okay? Do you think that might cause some problems? Absolutely, okay? So, number one, we got big sumo baby. Okay, number two, say, for example, we got a 100-pound woman soaking wet. Okay, trying to deliver this big sumo baby. That's going to be very hard on both her and the baby. Now, when we talk about complications for mom and baby, we're talking about, I'm going to get rid of this chat box here. We're talking about, you know, the size when it comes to the size. So we um, we want to control that baby from getting too big. Okay. So the other thing that can happen for mom if she has gestational diabetes is quite often it's very related to mom's like high blood pressure. Okay. If she has that big baby in there, she's at much higher risk for having a cesarean section, much higher risk of developing that high blood pressure and at a higher risk of developing type 2 later on in life. Not always, but sometimes later on in life. There's a lot of chances that she's going to deliver that baby preterm. Okay, not all the time, but sometimes preterm. Now, when it comes to baby, okay, baby stuff is we have that big baby sumo, okay, greater than 9 pounds. We also, because that baby's huge, the big thing what we look for is shoulder dystocia during the delivery. Okay, shoulder dystocia is a true emergency, and we really don't take that lightly because we have to get that baby out. So what happens with shoulder dystocia is the shoulder, okay, so this is the cervical opening, okay, the shoulder is getting stuck. This is my shoulder. The shoulder is getting stuck under that pubic bone, okay? And it can't move. So we have to get, so the head is stuck out here. The head is stuck, but the shoulder can't come out because the baby's so big, right? So we have to move that shoulder to move it so it can get into a position where it can come out. There's a couple of maneuvers that we talk about. The biggest one is called McRoberts maneuver. Okay, McRoberts. That's where we take and help mom get to knees to her ears. Okay, if she's in that position where she's ready to deliver, we want to try and widen that pelvis opening as much as we can. So we help mom bring her knees up to her ears. Okay, that helps kind of push the baby underneath of that pubic bone a little bit better. And then we also may need to give pubic pressure or suprapubic pressure. But keep in mind that we have to give that pressure in the right direction. Because if this shoulder is stuck under the bone and I push this way, okay, I'm actually making my shoulder wider. But if I push this way, I'm curling my shoulder in. So you always have to ask the provider which direction do they want, left or right. Okay, and they often tell you, Okay, don't push from the right, push from the left or whatever. But McRoberts is the position that you need to be aware of for your assessment. Okay. Other potential injuries that could happen for baby during that time is if you think about it, we're trying to get that baby's head out or the body out. The head is out, so we're kind of pulling downwards on that baby's head too to try and help that shoulder come up underneath. So by pulling, we're stretching all of this out. Okay. So we can end up with a brachial plexus injury because that's the brachial plexus nerve. Okay. So we might see a floppy arm if that were the case. The other thing that can happen is, and we may actually have to do this during the delivery, is to break the baby's clavicle bone. Okay. The shoulder that was presenting, if we can't get that shoulder to come up and under the pubic bone, we may have to break that clavicle bone so that it can go over top of one another to round the shoulder out. So we always look for, if we have a large baby, we always palpate both clavicles to see if maybe it is broken. And if it is broken, we often will feel and even kind of hear bony fragments. Okay, kind of like a Rice Krispies. If you're pushing on Rice Krispies, okay, you'll kind of feel and hear that sound. The other big thing that happens to these poor big babies is they have a rapid drop in their blood glucose levels because now they're not in that sugar water. They're delivered, they're not in that sugar water, but now their pancreas is working overtime. Okay. So their sugar is going to plummet very quickly. And we don't want that. We want to get them fed and make sure that that sugar, that their pancreas and their sugar levels are easily able to maintain themselves. They often come out floppy, so they sometimes have these breathing problems where they're, just exhausted from the delivery process itself because it was very hard on them. So they come out with sometimes having those breathing problems. So we have to really give babies some good stimulation to get them breathing on their own. And sometimes they come out with what's called hyperbilirubinemia, or they end up with jaundice. Okay, that's associated with the gestational diabetes. So here you can see we have big baby sumo here and a normal size baby. Okay, you can see all the fatty, chunky, even though they look delicious and you just want to yum them up, they're very chunky. Now, when it comes to which one of these babies do you think would survive the easiest? Do you think it would be big baby sumo or regular baby? It's going to be regular baby because they've already initiated all the regulatory functions of their body. But this baby is going to need to do a lot of extra work to bring itself back to homeostasis kind of thing. So glucose is the primary fuel for the fetus. It does cross the placenta, but the insulin from mom does not. The fetal pancreas responds to maternal hyperglycemia by producing large amounts of insulin. So mom's pancreas is working very hard for her, and baby's pancreas is working very hard for it. The fetal pancreas responds to mom or hyperglycemia. Insulin then acts as a growth hormone, so the fetus produces excess stores of glycogen, protein, and adipose tissue that then leads to what's called macrosomia. That in and of itself can lead to what we just talked about, those birth injuries, facial nerve injuries, clavicle fracture, what we call cephalohematoma. Those are the biggest ones. And then finally, the worst one is shoulder dystocia. And then, like I already said, we're at risk for developing that hypoglycemia because we're all of a sudden withdrawn. So here's a good discussion. So what are the risks to the fetus with poorly controlled pre-gestational diabetes as opposed to gestational diabetes? Hint, think of the point of development that they would be exposed to high blood sugars. When are babies typically going to get or develop problems? We talked about it yesterday. It's a specific stage. Embryonic stage. Yes, when all those organs are developing. If we have pre-gestational diabetes that's very poorly controlled, that baby's going to have a lot of potential issues. Not saying it will, for sure, but certainly is at a much higher risk than that person or that baby that does not have that exposure, right? So treatment for gestational diabetes, we talked about it in the Venn diagram. Typically diet control, following that healthy diet, monitoring your glucose levels. We would ask that patients keep a log and bring that log to them with every prenatal visit. Okay. Being active, getting regular physical activity, definitely monitoring baby's fetal growth or the fetal growth. How do we do that? How do we monitor growth again? Talked about this yesterday. Fundal height, yes. Yes, very good. And ultrasound, we can do an ultrasound if necessary, absolutely. Fund height is how we're monitoring fetal growth. Okay, definitely making sure we're doing some fetal kick counts to keep track of baby movements. Anytime we have a patient that is a high risk pregnancy, so gestational diabetes and hypertension, those are high risk pregnancies. We always set them up for regular testing at about 28 weeks and on, because we want to be able to make sure that we are keeping a good close eye on the baby and making sure that the baby is doing very well inside. So we typically set them up for testing, which includes a non-stress test and may or may not include a biophysical profile. Okay. If the diet is not enough, it's just not cutting it, then we're definitely going to try and have to do some, oral glycemics, hypoglycemics. Okay. All right, practice question. Which statement requires further education for a client who has been diagnosed with gestational diabetes? So we're looking for an incorrect statement. Okay. So I will need to stay on a diabetic diet. I'll perform glucose monitoring at home. My baby's at risk for having low blood sugars after they're born, or I should avoid exercise. D, avoiding exercise is not the right answer. We want them to increase it, if anything. Okay. Okay, this is your case study. All right, case study. So we have Mary. We're continuing with Mary. She's that 37-year-old Hispanic. She married Jose. This is their first baby. Remember from yesterday, she has that history of gestational diabetes. She had a cesarean section for a large baby. Okay. Her two first babies were very large. Okay. Her 1 hour GTT is 180. Okay. Is that low or high or normal? What should your GTT be? It's high. What should the normal GTT be? What is the normal GTT? Yes, definitely under 140. So this is pretty high. Okay, so what are your concerns? What additional assessments would you want to do? What education would you provide? And when would Mary need to return for her next appointment? We already talked about this one yesterday, right? But we didn't talk about her GTT, or did we? We did not talk about GTT, but we talked about everything else, correct? Or am I losing my mind? I hope I'm not losing my mind. Okay, so what would we do for her GTT? What are we going to ask her to do? What's her education? Diet and lifestyle changes. Very good. Okay. Specifically, if she's, more on the sedentary lifestyle, we want to increase her activity. Okay, what about kick counts? We'd want to have her do some kick counts. Okay, monitoring her blood glucose. Yep, definitely. Okay, when do you want her to come back? 4 weeks. Yeah, she's still 4 weeks. Okay, still 4 weeks. We do every 2 weeks when we hit that third trimester. Okay, when we hit that third trimester. Okay. Any questions? Because that's it for today's lecture. No questions? Everybody's happy? Okay, I'm going to spit out a few questions and I want to hear voices for answers. I don't want to hear or see nods or typing. I want to hear voices, okay? Voices. This is the voice, the use of the vocal cords, people. Vocal cords, okay? All right. What is the intervention for a late deceleration?
Flip fluid and O2.
Yes, very good. Very good. Thank you, Seth. Okay, what do we do? What's the specific maneuver called if we have a shoulder dystocia? I'm going to call on somebody here. Tiana,
Was it McRoberts?
McRoberts position. Very good. Okay, how often do we do prenatal visits in the first and second trimester? Tiffany.
Every 4 weeks.
Okay, good job. All right, let me think of some more questions here. What is the normal fetal heartbeat? People don't want me to call on them, they're leaving.
110 to 160.
Very good, Seth. What else? What are variable decelerations related to? Sophia. Sophia Vittoria. What are, there you go.
Variable decelerations are related to cord compression.
Very good. Okay. How about how often should ladies contract when they're in labor? Ava.
Every 2 to 3 minutes.
All right, good job. Fiona, ask a question that your peers can answer and call on anybody.
Oh boy. Okay.
Everybody's leaving.
Daniela, what is the cause of early decelerations?
Is that cord compression?
Early decelerations?
Head compression rather than cord. Variable.
Head compression. Variables are cord compression. All right, guys. Well, that does it for today. Remember to do your assignments, and I will see you guys all in the morning. Okay? Thank you. Bye.